my laptop also got nervous. A 19-year-old female with a recurrent left-sided chest pain and shortness of breath. Beginning with the patient particular, a 19-year-old female student, resident of Bhiwadi, Alwar, Rajasthan, belonging to the upper middle class family. Came with a complaint of left-sided chest pain for 4 days and shortness of breath for 3 days. Patient was apparently well 4 days back when she developed left-sided chest pain, which was sudden in onset, sharp and stabbing in nature, severe in intensity, and radiating to the left shoulder. Pain aggravated on deep breathing and coughing, relieved on lying on the left side. Patient also complained of shortness of breath since 3 days on day-to-day activities, acute in onset, and eventually progressed to rest. There was no history of trauma, fever, hemoptysis, palpitations, sweating, orthopnea, paroxysmal nocturnal dyspnea, retrosternal burn, vomiting, hematemesis, anorexia, and weight loss. Patient also had a similar episode 1 month back, for which she went to a physician in Bhiwadi. She was given pain medication for around 3 to 4 days, but the symptoms were not relieved. Patient visited a local hospital after 3 to 4 days, where a chest X-ray was done that showed a left-sided pneumothorax, for which a chest tube was inserted on the left side and was kept for 5 days in Alwar. Symptoms were relieved, chest tube was removed, and the patient was discharged. There was no history of tuberculosis, asthma, COPD, diabetes mellitus, thyroid disorders, or hypertension. There was no known allergies, no history of hospitalization, and there was no history of chest trauma. There was no delay in the development milestones with a normal menstrual history. Family history, there was nothing significant. Personal history, there was nothing significant, and there was no history of substance abuse. To summarize the history of the patient, we have a 19-year-old female student presented with the complaint of recurrent left chest pain and shortness of breath for last 4 days, 2 episodes in a month. Chest pain was aggravated on deep breathing and coughing, relieved on lying on the left side, and was associated with left shoulder pain. There was shortness of breath progressed from MMRC grade 2 to grade 4. Past history of chest tube insertion was 20 days back for pneumothorax. Now, I would like to ask the fellow colleagues, what is the clinical possibility of the history discussed above? So, whenever a patient comes to the OPD with the symptoms like chest pain or shortness of breath, we suspect that it could be involvement of 3 systems. These are respiratory, cardiovascular, and gastrointestinal symptoms. As there are some points against the cardiovascular and gastrointestinal systems, they are less likely. So, majorly we have to focus on the respiratory system. So, in general physical examination, patient examined in emergency in a well-lit room with proper consent with a female attendant. She was restless, conscious, well-oriented to time, place and person. She had a height of 160 cm with a 48 kg and BMI of 18.75 kg per square meter. Vital signs presentation, pulse was of 98 beats per minute in right radial artery in supine position. She was tachypneic with a respiratory rate of 22 cycles per minute, and she was hypoxic with a saturation of 88% on room air, which improved on 3 liters of O2 to 94% by nasal drops.
ये पल्स राइट में मेजर करते हैं, लेफ्ट में मेजर करते हैं?
राइट में मेजर कर सकते हैं।
कर तो सकते हैं, बट इतनी नॉर्मल
राइट एज वी स्टैंड ऑन राइट
साइड, फिर दोनों तरफ करो, पैरों में भी करो।
We are not suspecting a vascular disease, that's why we didn't do
regularly. You do not check the dominant part of the body.
Stand on the right side. Pallor, icterus, clubbing, cyanosis, lymphadenopathy, and pededema was absent. Coming to the systemic examination of the respiratory system. Upper respiratory tract appears normal. There was flaring of alar and SI was present. Examination of the respiratory system inspection. Shape of chest was normal. There was no spinal deformity. Symmetry of chest. Chest was asymmetrical. There was left side bulging was present. There was no drooping of shoulder. Trachea appears to the right. Apical impulse was not visualized. Use of accessory respiratory muscles was present. Visible scar present on the left side at mid-axillary line at the level of nipple. That was of the previous intercostal drainage. Pulsation and dilated veins were not present, and bilateral breast and axilla appears now. The movement of the left side of the chest was diminished. On palpation, inspection findings were confirmed on palpation. There was no local rise of temperature, no tenderness, no crepitus. Trachea was shifted to the right. Movement of chest was diminished. Tactile vocal perimeters was absent on the left side. Apex beat was not palpable. And the chest expansion was 3 cm, that is reduced. On percussion, a hyper-resonant node was heard on the left side and the liver dullness at the 6th intercostal space, on the right side. On auscultation, breath sounds diminished in the left side and vocal resonance was also diminished on the left side. Other systemic examination, the other systems were normal and there was no focal deficit. To summarize the history and examination, a 19-year-old female student with a complaint of recurrent left chest pain and shortness of breath, aggravated with deep breathing and coughing, relieved on lying on the left side and was associated with left shoulder pain. Shortness of breath progressed from MMRC grade 2 to grade 4. There was a past history of chest tube insertion 20 days back. On examination, the patient was dyspneic and hypoxic with a saturation of 88% on room air. Left-sided chest movements were diminished, left tactile vocal perimeters were absent, and left hyper-resonant node was heard on the left side. Air entry was decreased on the left side of the chest. Now, I would like the fellow colleagues to brainstorm the differentials after general physical examination. So, these were the differentials after the history. But after the examination, gastrointestinal and cardiovascular diseases can be ruled out, and therefore we are left with the differential of the respiratory system. That is pneumothorax, emphysema, tuberculosis can also be there. But as there is no history of smoking and the patient is young, it is less likely for emphysema. So to differentiate between the differentials, we request for a chest X-ray. Now I would like to ask any fellow colleague to tell you that what they can appreciate in the X-ray. As there is a hyperlucent area on the left side and there is a collapse of the lung on the left side, it can be due to pneumothorax. All routine blood investigations were done and were within normal limits. As the chest X-ray was suggestive of left pneumothorax, and that is the emergency. So,
in a young lady with pneumothorax, and obviously this is spontaneous pneumothorax, what else you should have shown us on the right side where the lung is fully sealed? What is one of the possible causes of a spontaneous pneumothorax?
A bulla or
So you should have said that on the right side where the lung is fully normally seen. I don't see any bulla.
So 20 French Toka catheter was inserted in the left fifth intercostal space and was connected to an underwater seal bag. A repeat chest X-ray was done and the chest X-ray showed that the tube was patent and the lung did not expand. So for that, a respiratory medicine reference was taken for further evaluation. And now I would like to invite my colleague, Dr. Nisarg, Padh, for the respiratory department, medicine department, to throw some light on the various differentials of the case.
Very good morning, everyone. My name is Dr. Nisarg. To summarize up till now, we have a 19-year-old non-smoker, menstruating female, referred to respiratory medicine with recurrent spontaneous pneumothorax. The chest X-ray showed left-sided pneumothorax with ICD tube in situ and the partial expansion of the lung with no other obvious parenchymal lesions. ICD tube was functioning properly with water seal bag full of air bubbles suggestive of an air leak present. So the bronchopleural fistula or the abnormal communication between the bronchus and the pleural cavity was present, which was shown by the air bubbles present in the underwater seal bag. We have the Serfolio classification of the air leak, where if there is no movement in the tube or and the bag, it is called absent. If there are bubbling in the underwater seal bag during forced expiration, particularly when the patient is asked to cough, it is grade 1. On expiration is grade 2. On inspiration is grade 3, and on grade 4, continuous bubbling is present in an underwater seal chamber on inspiration and expiration. Interestingly, the grade 4 BPF or air leak is seen in patients who are mechanically ventilated or if there is presence of very large pneumothorax. So the video shows the air bubbling present in the underwater seal bag. So coming to the causes of recurrent pneumothorax, it could be connective tissue disease or any autoimmune disease. The points in favor are that the patient was young and a female, and the points against it was that there was no extra pulmonary symptoms or involvement and serum ANA was negative. It could be catamenial pneumothorax. The points in favor are the patient was young and a menstruating female, but the points against it was that the patient was non-parous, no menstrual abnormality was present, and the pneumothorax was left-sided. So catamenial pneumothorax, 90% of the cases that we see are right-sided pneumothorax. So it could be one of the point against the diagnosis. It could be lymphangiomyomatosis because the patient was a female and initial presentation was a pneumothorax. But again, there was no extra pulmonary symptoms or involvement present. It could have been Langerhans cell histiocytosis because the presentation was recurrent pneumothorax. And the points against it was that the patient was a female, she was a non-smoker. The chest X-ray was pretty clear, and there were no extra pulmonary involvement. It could have been obstructive airway disease due to either COPD or asthma. Pneumothorax presentation was the points in favor, but the points against COPD was that it is very uncommon at this young age, and the patient was a non-smoker. While patient had no seasonal or diurnal variation of symptoms, there was no wheezing present, no nasal symptoms present, which could be points against asthma. So any other underlying parenchymal disorder could have been present, which could have been missed out on a chest X-ray. Hence, an high resolution CT chest was advised. Coming on a rate of recurrence. Sorry, sir. Sir, there could be in the respiratory system there could be catamenial hemoptysis. Catamenial pneumothorax is there. Catamenial migraine can be present. Catamenial epilepsy can be present. Where the already existing disease increases in magnitude and the medications do not work properly. The rate of recurrence is approximately 33%, ranging from 23 to 52%, and it usually occurs within 1 to 2 years after the first episode. The risk factors for recurrence of pneumothorax are greater height, lower weight, smoking, and a history of previous episodes. So a risk is increased to more than 60% after the second episode and to 83% after the third episode. The risk of congenital pneumothorax is only 5 to 10%. So to discuss the findings of the HRCT test that was done, I would like to invite Dr. Ankit Godara from Radiology.
Good morning, everyone. In the first slide, in the left side of screen, we are showing a normal CT lung window image, and in the right side of screen, it is a normal CT mediastinal window image for reference purposes. In the next slide, in the left side of the screen, it is a normal HRCT coronal window of a normal person, and in the right side of the screen, it is HRCT available HRCT section coronal image. Here we can see a pneumothorax on left side with partial collapse of adjacent lung parenchyma with a small air-filled sac is seen apico-posterior segment of the left lung. To better view, we have zoomed the section and coronal section. This is air-filled sac present in the subpleural location, which is subcentimetric and likely suggestive of a bleb. Now I would like to Dr. Nisarg for further discussion.
So the HRCT test was pretty clear that the presence of bleb is the reason for recurrent pneumothorax. Bleb is a small localized collection of air within the cellular layers of the visceral pleura that is contiguous with the lung parenchyma. So it arises as a result of a congenital weakness in the connective tissue of the subpleural alveoli. Blebs are found most commonly in the lung apices, but why? So regional differences in the mechanical stress are known to exist within the lungs. So in an upright posture, a gravity dependent gradient of negative intrapleural pressure extends along the length of each lung, so that the distending forces are greatest over the lung apices, just as a loosely coiled spring when suspended from its uppermost coil. So as shown in the picture, the maximum pressure is present on the uppermost part of the coil. Here are some management options for the bleb. First option is endobronchial closure of
Before
the...
you go on to management, can you please explain what is the difference between a bleb and a bulla?
Sir, main difference is the size. Bleb is 1 to 2 centimeters in size, while bulla is it can range from either 1 to 2 centimeters to it can occupy the whole lung. And sir, the other difference is the origin. Bulla arises from the secondary lobule, while bleb arises as we seen from the cellular layers of the visceral dura. They can be differentiated on a HRCT test easily and managed properly.
So is the etiology different? Is the management different for the two?
Sir, bleb, subpleural blebs can occur, the etiology is not particularly known. It can occur in all tall, thin patients, while bulla can be present along with emphysema. So it can either be idiopathic, or it can present with emphysema in the chest or COPD and other diseases. Bullas can also be present in various occupational lung diseases. Compensatory emphysema can be the cause for bullas. And sir, the blebs, when small blebs collate with each other, they can even communicate with each other and form a large bulla in the lung. The first option is endobronchial closure of the air leak. Since lesion was situated peripherally and the possibility of endobronchial leak closure failure was quite high, hence this option was not considered. The other option was open thoracotomy with bleb resection. This procedure carries more morbidity and a longer hospital stay, and considering the patient was a young female, this procedure also might have some cosmetic issues. And the last option is video assisted thoracoscopic surgery or VATS with bleb resection. This carries less morbidity, it has a lesser hospital stay, and it carries a cosmetic advantage. Hence, VATS was advised. The patient was referred back to the Department of General Surgery. I would like to invite Dr. Apoorva back to the podium to tell us about the further treatment plan.
As the patient was a young female, we chose a minimally invasive method for the surgical management, and the best suited modality was video assisted thoracoscopic surgery. MATS has several diagnostic and therapeutic indications as listed above. But for our indication, for the same was the presence of pulmonary bleb and a bulla resection, which was present in the HRCT, leading to a persistent pneumothorax. So before getting into the aspects of VETS, video assisted thoracoscopic surgery, I called Dr. Naazneen Ali to discuss the anesthetic challenges for the same.
Good morning, respected Chairperson sir, Chairman sir, and respected teachers and my dear colleagues. I am Dr. Naazneen Ali from the DM resident from the Department of Cardiac Anesthesia, and I will be presenting the anesthetic management of this case under the guidance of Dr. Godara sir. So the anesthetic challenges which we faced in this particular case were a triad of lung protection, one lung ventilation, and post-operative concerns. Under lung protection, our aim was to prevent the bulla rupture, acute lung injury, atelectasis, and to negate the effect of carbon dioxide insufflation. For one lung ventilation, our preferred choice was a double Newman tube to provide better surgical exposure and to provide lung isolation. Our post-operative concerns were mainly pain control and to avoid any post-operative pulmonary complications such as atelectasis, respiratory failure, and to ensure patient was hemodynamically stable post-operatively. Out of the various modalities to provide this patient, we chose thoracic epidural, and we didn't go for opioids, and it could have led to the post-op respiratory depression to this patient. So thoracic epidural was our choice, and for this we chose T8, T9 thoracic epidural space, patient being in the sitting position. A test dose of 3 ml 2% lignocaine after negative aspiration for confirmation, and this was done for post-operative pain management and to help the patient in post-surgery physiotherapy. The challenge which we faced in this patient was the risk of neuraxial induced stress causing coughing, which could have led to the bulla rupture, and this was not encountered in our case. Our Our plan was to isolate the lung with a double lumen tube. This is a diagrammatic representation of the left-sided double lumen tube which we use in this patient. It has two lumen, the tracheal and the bronchial, tracheal cuff, a bronchial cuff with two ports, and the two pilot balloons for the bronchial and for the tracheal. We connected to the ventilator with the help of port connectors. For ventilation, we chose lung protective strategy with a tidal volume of 4 to 6 ml per kg of the ideal body weight, respiratory rate of 16 per minute for initial 30 minutes, which was adjusted according to the PaCO2 levels, inspiratory flow rate of 60 liters per minute, positive end expiratory pressure of 5 centimeter of water, and the inspiratory pressure was less than 30 centimeter of water. Our saturation goal was 88 to 95% as per the ARDS net protocol. The major determinants of perfusion in our case were hypoxic, pulmonary vasoconstriction and gravity. The figure represents differentiation between two lung ventilation and one lung ventilation, with the patient being in the left lateral position under general anesthesia. The shunt ratio changes from 10% to 27.5%, with the dependent lung being more perfused and the non-dependent, that is the operative lung, being less ventilated. Hypoxia. During the course of our management, we encountered an event of hypoxia during one lung ventilation. This was managed by checking the position of the tube, increasing the FiO2 to 100%, and employing recruitment maneuver of 20 cm of water for 15 to 20 seconds and a PEEP of up to 10 cm of water to the ventilated lung. A continuous positive airway pressure CPAP was applied to the non-ventilated operative lung of 1 to 2 cm of water. Along the course, we made sure that the hemodynamics was stable and there was no compression of any major vessels or worsening of the ventilation perfusion mismatch. Following the successful management, following successful surgery, our aim was to extubate the patient, and for this we followed the criteria of adequate oxygenation with the saturation of more than 92%, PaO2 levels of more than 60 mm of Hg, adequate ventilation with a tidal volume of more than 5 ml per kg, spontaneous respiratory rate of more than 10 per minute, EtCO2 of less than 50 and PaCO2 of less than 60 mm of Hg respectively. Patient being hemodynamically stable, neurologically intact following verbal commands, and there was full reversal of muscle relaxation with a TOF ratio, train of 4 ratio of more than 0.9, a sustained 5-second head lift, and patient having an intact cough and gag reflex. Now I would like to invite Dr. Apoorva from General Surgery to take this case further.
Here is the diagrammatic representation of VATS procedure which was done in our patient. So for steps, 3-port method was used. A 30-degree scope was inserted from the 7th intercostal space in the left decubitus position. 2 standard ports were made with a good triangulation. And a diagnostic thoracoscopy was done in which we found a bleb at the apex of the left lung. The rest of the left lung was examined thoroughly and there was no other site of leak, no bulla or disease segment was found. Now I would like to ask the fellow colleagues, has anyone ever seen a beating lung like instead of a heart like this?
What is your name? Your name? What is the meaning of Nisarg? It's a very uncommon name. Your parents have kept. Nature of what? Nature of fire. And this diagnosis is confirming formation of bulla, nature of fire.
So the disease portion of the apex of the left lung was...
Before you proceed, I must compliment the anesthesia team that such a involved bleb did not rupture during the intubation, ventilation and all, it remained intact.
The disease portion of the apex of the lung was hit. Stapler was placed beneath it. The disease portion was dissected and the tissue was sent for histopathological examination.
For the sake of the non-surgical audience, you should explain that the conventional method of lung resection was dividing it like any other structure and suturing, which had its own problems. Staple has made very easy for us to do such kind of pulmonary dissections. It is convenient, it is easy, and the chances, especially when we apply these staplers, there are two types of staplers. One have two rows of staplers, and one recent ones have 3 rows. So it makes it more hemostatic, and in the case of the lung, more important is that it makes it air leak.
So the air leak test was also done, and there was no evidence of air leak was observed. Patient was shifted to ICU
How
after
did you do
rescue.
the air leak test?
Yes, sir.
How did you do the air leak test?
So we filled the lung with NS or any kind of liquid, and we checked for the buckling inside the continuation. Actually, like as shown in the videos, cut it and then send it to the bag. With the help of the suction, put the NS inside the lung cavity, pleural cavity.
Gaurav, at this stage, is it possible to change from a single lung ventilation to double lung?
Yes, sir. That is why then only we can inflate the collapsed lung. So sir, the beauty of double lumen tube is anytime you can choose your ventilating lung, either both of them, right or left, whichever you want to do. That is the tough and yes. That is why we have chosen the double lumen tube. Otherwise, lung isolation can be done by various methods, including bronchial blockers and everything. So we have chosen this.
The patient was shifted to ICU after respiration, and we were very happy to state that the patient did not require any oxygen support and was able to maintain saturation, 96% of saturation on room air on the post-operative evening. On POD 2, the drain output was 10 ml and a repeat X-ray was done, which showed a normal lung expansion. And thus the chest tube was removed and the patient was discharged asymptomatically. There are various advantages of VATS which help make the follow-ups of our patient uneventful with early recovery. We can proudly say that the patient is doing well till date. Here are some advantages of VATS that are less post-operative pain, faster recovery, reduced overall cost, lower overall morbidity, less complication, less blood loss, and cosmetic advantage also there as the patient was 19-year-old. So why we selected this case? The reason is that because of the rate of the occurrence of a primary spontaneous pneumothorax in female is 1 out of 1 lakh with a male-female ratio of 6:1, and the peak incidence is mainly seen in the 3rd to the 5th decade of life, whereas our patient is a 19-year-old female. The risk of recurrence increases to more than 60% after the 2nd episode, which is why we called the patient for multiple follow-ups, and we were content with her recovery with no fresh complaints till date. So these were some references which show the primary pneumothorax is more common with the patient with a low body mass index. And some meta-analysis confirming that the VATS procedure for the spontaneous pneumothorax is superior to other surgical methods. Now I would like to invite Dr. Abdesh Sharma sir, minimal invasive surgeon, associate professor in our department, on the podium to say some few words.
Very good morning, Mahatma Gandhi. The key lines of this case. Key lines of this CCR was the most complicated disease can present as a simple manifestation like in our case like chest pain and shortness of breath. So therefore as a young surgeon or young physician we should be vigilant and broaden our horizon to correctly diagnose the patient even at the periphery center like our case was misdiagnosed at the Bhiwadi. A minimally invasive thoracoscopy surgery may be useful in this type of the patient. One can avoid major surgical procedure like thoracotomy, and thoracoscopy surgery has cost-effective, faster recovery, minimal blood loss, and less morbidity. The last 3 decades were fully dedicated to laparoscopic surgery, and next few decades will be of robotic surgery. And these were possible because of institutions like our Mahatma Gandhi, the infrastructure and easy availability of the instrument, we can easily perform this procedure totally. Thank you, sir.
So our patient was discharged within 3 days after the procedure, and here is what she had to say.
And I was diagnosed with pneumothorax, and I was operated in Mahatma Gandhi, a bed surgery. So initially I was diagnosed in Bhiwadi hospital that I have a pneumothorax, and the doctors were not helpful. So they did that tube, what's the procedure in chest tube. So then my family doctor suggested me to Mahatma Gandhi hospital. So I came here, and doctors were really helpful, and he helped me mentally do that it will be all right after 7 months. I will handle everything. So after all the tests and everything, he said a date for surgery that yeah, we can plan the staff and all the doctors in the hospital were really helpful, and they were really taking care of me mentally and physically, and I was able to throw all this. And yeah, so I hope Mahatma Gandhi will do great things for other patients too, and the staff and the
I would like to extend my heartfelt vote of thanks to everyone who made this operative procedure successful.